is not having many but business is from today I am going to present maternal mortality under the kind supervision of Professor. The learning outlines of today's presentation is introduction to the maternal mortality, maternal mortality, death, death, obstetrical death, measurement of mortality, also maternal mortality, prevention actions for mortality, and the recent advances. By the end of this presentation, participants will be able to describe local death and death obstetric causes, measurement of maternal mortality, causes of maternal mortality, prevention, and actions taken to reduce maternal mortality. Every day, approximately 830 women die from preventable causes related to pregnancy and childbirth. 99% of maternal deaths occur in developing countries. Maternal mortality is higher in women having rural areas and among rural communities. Young adolescents face a higher risk of complications and death resulting from pregnancy and skilled care before, during, and after childbirth can save the lives of women and newborns. Between 1990 and 2015, maternal mortality worldwide dropped by about 44%. Between 2016 and 30, as a sustainable development goal, the target is to reduce the global mortality ratio to less than 70 per 100,000 lives. So the Millennium Development Goal 5A is to reduce maternal mortality ratio by three quarters between 1990 and 20. And the target 5B is to achieve uh, the university access to
Ay, Raja Saab.
these are the subtypes. It says that 85% of women will deliver normally, 10 to 15% of women will develop complications, and 55% of women will need surgical intervention. 20 to 25% of deaths occur during pregnancy, and 40 to 50% deaths occur during labor and delivery, and 25 to 40% deaths occur after childbirth. 5,29,000 deaths per year are 400 per 1 lakh live births. One death per million, 1% in 12 countries, and the range is 24 to 830 per 100 live births, and 19 by 20 countries with high maternal mortality rates are in sub-Saharan Africa. These are the lifetime risks for women of mortality. In Africa, it is highest, that is 1 in 5. In Asia, it is 1 in 11. In Latin America, it is 1 in 11. And for 12 countries, it is 1 in 125. This is the situation for Pakistan for the maternal mortality that is conducted in the 2020. The highest maternal mortality recorded in Pakistan is in the Balochistan province, that is 298 per 100,000 lives. Now, what is maternal mortality? Maternal mortality is death of a woman who is pregnant or within 42 days of termination of pregnancy, irrespective of the site or reduction of the duration of pregnancy from any cause related to or aggravated by pregnancy or its management. Now, the death of obstetric causes are the deaths resulting from obstetric complications of the pregnant state, that is during pregnancy, labor, and puerperium, from intervention omissions or incorrect treatment, or from a high chain of events resulting from any of the above are called death of obstetric causes. While the indirect obstetric causes are those resulting from previous existing disease or disease that developed during pregnancy and that was not able to and was not due to direct obstetric causes but was aggravated by the pathological effects of the pregnancy. Now, the late maternal death. It is death of a woman from death or indirect obstetric causes more than 42 days but less than 1 year after termination of pregnancy. So what is pregnancy literature? It is defined as the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the cause of death. To facilitate the identification of maternal death in circumstances in which the cause of death attribution is indicated, international classification of disease death addition is introduced a new category, that is pregnancy-related death. Now, measurement of maternal mortality. It can be by maternal mortality ratio, maternal mortality rate, lifetime risk of maternal death. Now, the maternal mortality ratio. This represents the risk associated with each pregnancy that is offered. It's calculated as the number of maternal deaths during a given year per 100,000 live births during the same period. This is usually referred to as rate, though it is a ratio. The appropriate denominator of the maternal mortality ratio would be the total number of pregnancies. Live birth, fetal deaths, are stillbirth, induced and spontaneous abortion, ectopic and molar pregnancy. However, this figure is seldom available and thus the number of live births is used as a denominator. In countries where maternal mortality is high, denominator use is per thousand live births, but as this indicator is reduced with better subsidies, the denominator use is per 100,000 live births to avoid figure in nominal decimal. Now, this is the pre-delay model. That is the delay that occurs in home during transportation and at the level of a health facility due to inappropriate health services. Uh, in first delay model, that is the delay in decision to seek care due to warning signs, poor understanding of complication and risk factor in pregnancy, and when to seek medical help, ignorance of sexual and reproductive health risk. In our culture, the uh, the decision or the delay in decision by the family member is the first number of delay. The second delay is due to transportation. That is delay in reaching the healthcare facility due to request help and attention by a timely manner. Distance to health center and hospitals over roads and infrastructure, delay in search for care by pregnant women, and in our culture it is due to the poor condition of the roads. The third delay is delay in receiving adequate health care due to delay in availability and cost of transportation, poor facilities and lack of medical supplies, inadequate training and poorly motivated staff, inadequate referral systems. Then the last delay is lax in health quality care. That is even that cause poor attention in health services, medical and inadequate administrative work. This is the first delay that occurs during home. This is second delay that occurs due to delay in transportation. This is third delay that is due to delay in facility providing healthcare, and this is after visit that is inability to seek care. Now the causes of maternal mortality. 20% causes of all the maternal mortality are due to intact causes, while the 80% causes are due to dead causes. The four major causes are hemorrhage, infection, eclampsia, and obstructive labor. Underlying factors may be the socioeconomic or the nutritional factors. The impact of maternal death. Children who lose their mothers are more likely to die within 2 years of maternal death. 10 times the chance of death for the neonate and 7 times the chance of death for infants older than normal. 3 times the chance of death for children 1 to 5 years. Enrollment in school for younger children is delayed and older children often leave school to support their family. Many social causes are early marriage, gender discrimination, illiteracy, desire for selective sex of child, female fixed site, and the domestic violence. Economic issues are lack of money, lack of family transport and communication, delay in taking decision and improper dietary habits. Medical issues are lack of antenatal care services, lack of emergency obstetric care services, lack of blood and blood products, lack of restricted drugs, junior staff dealing with high-risk cases without supervision, delay in diagnosis, and the work at wrong diagnosis. So the prevention of maternal mortality, the highest level by which the maternal mortality can be prevented is by health education. That is centered at the age at marriage, utilization of healthcare services, awareness, prenatal care, nutrition, education, importance of immunization, and a basic limitation of births. Second, by health infrastructure, provision of healthcare services at remote and rural areas and urban some improved staffing facilities of essential and obstetric care, and the training of traditional birth attendants. So, for reducing maternal mortality, there are also the facilities of safe abortion services and health education about the contraception. For healthcare delivery, emergency management of eclampsia third stage induction at the primary healthcare level and employing quad services and the adoption of a small family size norms and the prevention of anemia. There is a concept of 100 tablets that is at puberty at the time of marriage, during pregnancy, and during lactation. Non-health strategies are poverty education, improvement of literacy, women's empowerment measures, improved communication, improved transport facilities. and the action taken for safe motherhood and legislative and policy actions, society and community and health sector action. The society and community actions are national, regional, and district safe motherhood community committees, health facility and community committee, raising awareness on digital science, providing of essential drugs for clean reviews. Traditional birth control should have remote and accessible. Teachers should be trained in improving maternal nutrition, addressing certain diseases like malaria, TB, respiratory tract infections, sexual transmitted infections, HIV/AIDS, and hepatitis, preventing unwanted births and reducing unsafe abortions. Antenatal clinics and the skilled worker attendance, postnatal care, abortion services, emergency obstetric care services, iron politics and injection, tetanus stroke site, and the family planning services, they all should have to be available for reducing the maternal mortality. The first level maternal care is such care that has three functions. That is, the birth takes place in the best of the circumstances. Second is to resolve complications as they arise. And the third one is to respond to the life-threatening emergencies. It is organized in midwife-led birthing centers, combined culture from documented in a non-medicalized setting with professional skill care, the necessary equipment, and the protection for emergency evacuation. Now the backup care. Ideally, it is provided in a hospital where doctors, specialists, skilled general practitioners, or mid-level people with appropriate skills are available. It's linked with the first level care. It is available around the clock, and the emergency and non-emergency conditions are dealt with. Both first level services and backup care could be rolled out simultaneously. Now the essential obstetric care. That is, to be the registration of pregnancy in the first 12 to 16 weeks and a free prenatal checkup assistance during delivery get by a skilled birth attendant and at least three postnatal checkups. For a microbirth plan, inform the mother and the family about the four I's that are namely inform dates of three antinatal care services and technoscopic injection and ensure these are provided and identify the health center for all the referrals, identify the placement and identify the expected date of delivery. The challenges in maternal health are establishing data based on maternal mortality, high pregnancy behavior, poorly too many and too close, urban-rural divide, poor rate of institution deliveries, lack of skilled care at work, poor implementation of programs, lack of women empowerment. Now, the 10 action messages for safe motherhood are advanced safe motherhood for women and
हमें तो तुमसे डर लगता है
قالوا لا empower women and ensure choices. Save motherhood is a vital economic and social investment. Delay marriage at first birth. Every pregnancy faces risk. Ensure skill awareness at delivery. Improve access to quality reported health services. Prevent unwanted pregnancy and address unsafe abortion and measure progress. And the power of partnership. UNICEF response for the reduction in maternal mortality are all babies and mothers entitled to affordable, high-quality healthcare before, during, and after pregnancy. To make services accessible to all, UNICEF and partners adopted the Every Newborn Action Plan, a global roadmap to reduce newborn mortality. As part of this commitment, UNICEF supports communities to provide essential packages of high-quality maternal and newborn services such as home visits and caregiver care that uses skin-to-skin contact, putting parents and babies to increase their chances of survival. UNICEF also works with partners to alleviate maternal and newborn tetanus, collect information on pregnancy and healthcare workers to address the specific needs of adolescent mothers. The next one is the WHO role in reduction of maternal mortality. Improving maternal health is one of the WHO's key priorities. WHO works to contribute to the reduction of maternal mortality by increasing the research evidence, providing evidence-based clinical and programmatic guidance, setting global standards, and providing technical support to the member states on developing and implementing effective policy and programs. As defined in the Ending Preventing Maternal Mortality Strategy, WHO is working with the partners in supporting countries towards addressing inequality in access to and quality of the reproductive maternal and newborn healthcare services. Now, this is the response by the WHO, that is to ensure universal health coverage for comprehensive reproductive maternal and newborn healthcare services, and to address all kinds of maternal mortality, reproductive and maternal morbidity and related disabilities, and strengthening health systems collect high quality data in order to respond to the needs and priorities of women and girls, and ensuring accountability in order to improve the quality of care and equity. Now, these are the initiatives to reduce maternal mortality and the severe maternal morbidity in the United States. Maternal mortality and severe maternal morbidity and the critical health issues in the United States with unacceptability, high rates, and racial, ethnic, and geographical disparities. This review briefly discusses the selected initiatives to reduce maternal mortality and severe maternal morbidity in the areas of data and surveillance, clinical workforce training, patient education, telehealth, comprehensive model and strategy, and clinical guidelines, protocols, and wonders. So the final message is that the childbirth is a miracle of life. It should not become a nightmare of death. So this is the time for the recent advances. The first article in the recent advances is praying until death, revisiting the three delays model to contextualize the social cultural factors associated with the maternal death in a region with high prevalence of eclampsia in India. And this study uses the attractive 3 days marriage model to assess the socio-cultural barriers associated with the maternal mortality in West Bengal, India. The methodology that it was a retrospective mixed method study which uses facility-based as well as community-based approaches to explore factors associated with the maternal deaths. They reviewed 17 maternal death causes wherein a verbal autopsy technique was applied on 40 cases. The chi-scatters and multivariate logistic regression model was applied to accomplish the study objectives. The results show that the delay in seeking care, that is the type 1 level of delay, was the most significant contributor to maternal death. The second major impacted contributor to maternal death and was the delay in reaching first level of health facility, that is the second type of delay. And while delay in receiving adequate care at the health facility had a role in 18.9% maternal death. Women staying at long distance from the health facility have reported high type uh, high type 2 delay as compared to their counterpart. This study also indicates that the women belonging to Muslim community were 2.5 times and 1.6 times more likely to experience type 1 and type 2 delays in Hindu women. The verbal process read that type 1 delay is attributed to the underestimation of the gravity of the complications, culture, belief, and customs, recognition of danger sign, knowledge, and attitude towards seeking medical care, arranging transport, and financial constraints were the main barriers of delay in seeking care and reaching the facility. The conclusion that this study found that the type 1 and type 2 delay were major contributors of maternal deaths in the study region. Therefore, to prevent maternal death effectively, action will be required in areas like strengthening the functionality of the referral networks, expand coverage of healthcare, and raising awareness regarding the maternal complications and danger signs. The second article is the influence of social and cultural practices on maternal morbidity, a qualitative study from the South Punjab of Pakistan. This current study aims to explore social cultural factors leading to delay in seeking care in maternal health care in southern Punjab, Pakistan. In methodology, they use a qualitative method and perform three types of data collection with different target groups. First is 60 key informant interviews with gynecologists and four focus group discussions with lady health workers and the case studies among family members of the deceased mother. The study was conducted in Dera Rajasthan, situated in South Punjab. The data was analyzed with the help of thematic analysis. The study identified that delay in seeking care and potentially resulting maternal mortality is more likely to occur in Pakistan due to certain social and cultural factors. Poor socioeconomic status, limited knowledge about maternal care, financial constraints among rural people were the main barriers of seeking care. The low status of women and male domination keeps women less informed. The preference for traditional birth attendance results in maternal deaths. In addition, early marriage and lack of family planning, which are deeply uh, entrenched in cultural values, religion, and traditions. That is the influence of traditional spiritual healers, preventing young girls from obtaining maternal health care. The conclusion that the prevalence of high maternal mortality is deeply alarming in Pakistan. The uphill struggle to reduce deaths among pregnant women is firmly rooted in addressing certain social cultural practices which create constraints for women seeking maternal care. The focus on poverty reduction and enhancing decision-making power is essential for supporting women's right to medical care. So the time for the MCQs. First MCQ is the maternal mortality ratio reflects whether the number of pregnant women in the community, whether the general health of the woman, the standard of care for pregnant women. D option is both the health of women and the standard of care available. And the last option is the health state of children in the community.
D.
Yes, it's D. Both the health of women and the standard of care that's available. Second MCQ is the Millennium Development Goal 5A, adopted at the United Nations Millennium Summit in 2000, stipulated to reduce maternal mortality by 3 quantities until end of 2030. Progress reports indicate that the first country will create missed goal. This statement regarding the maternal mortality is wrong. Whether maternal mortality ratio is defined as the number of mothers who die due to delivery-related complications during a given period of time. A maternal mortality ratio of 4 by 100,000 is reported for Japan is comparable to that of developing nations. Maternal mortality ratio is defined by the number of maternal deaths related to childbearing divided by the number of live births per 100,000 in that year. The option in areas where studies on mortality are unreliable, the sisterhood method is the recognized method to approximately calculate maternal mortality. Last option, more than 90% deaths are reported in developing nations. Which is the wrong option among it's A. Maternal mortality is defined as
B.
and no, it's alpha. Then maternal mortality is defined as the number of mothers who died due to delivery-related complication during a given period of time. It's not the maternal mortality ratio. Maternal mortality ratio is number of women dying during pregnancy or due to pregnancy death. And after the 42 days after the termination of pregnancy, it's considered the cause of death by per 100,000 women. So this is not wrong option. While D is not wrong because sisterhood method is also can be used for calculating maternal mortality where the maternal deaths are not available. Question third is a 35-year lady, a mother of 5 children, presented in emergency with loss of consciousness and fits on second postpartum day could not survive. In Pakistan, maximum term mortality was the following items. That the age of mother less than 80 years, chemotherapy and multipara poor previous pregnancy outcome or the delayed referral.
E.
Yes,
E.
the delayed referral as it is also given in the recent update. Question 4 is a lady during delivery at home by untrained died where complications before delivery that did not inform the family of the situation until condition becomes serious. Even knowing the gravity of the situation, or further delay in decision to take her to hospital and management of transport took place. Major reason for high maternal mortality and morbidity in Pakistan is due to delay in decision by delay in decision by family, delay in transport, delay in referral system, delay in appropriate treatment. It's delay B. That is delay in decision by the family members. Uh, the highest reason of maternal mortality in Pakistan. Fifth and sequel, the three-daily model is being used in research project to examine its applicability and potential to assist a solution-based strategy for gaining access to intrapartum care in the XYZ community. The study resulted in the conclusion that a shortage of government and supply in the healthcare facilities is to account for the delay. In this scenario, political level of delay is whether first, second, third, fourth, or fifth level delay. It's the third level of delay in 3D model as the shortage of equipment or the inappropriate healthcare services is the third level of delay. First is delay in home, second is delay in transport services, and the third is delay in seeking care or the inappropriate health facilities. Sixth MCQ is in poor properly developed community-based safe motherhood instruction can effectively address all barriers and at the family and the community level. No safe motherhood program can successful until dash delays are addressed, whether culture, socioeconomic, transport costs, poor attitude of staff are by providing adequate health education and awareness as well as skilled personnel and improved transport services. What is the correct option? It's E. The three-day model identified three critical phases that could directly affect the mothers and the baby survival. The third driver delay is lack of transport, lack of money, lack of transport, traditional these are the transport costs.
It's B.
Yeah, it's the lack of train server that is the third level of delay. Third level of delay.
B.
Eighth MCQ is over the 40 verbal autopsies, 35 women delayed seeking medical attention in ABC hospital. Underestimating the seriousness of the communication, culture, beliefs, and norms experiences with the healthcare system are all labeled for the delay. Some people have mentioned a barrier to getting medical care is not having enough money. In this scenario, the critical level of delay is whether first left, second, third, fourth, or fifth delay. It's A, first level of delay. Ninth MCQ, the majority of maternal deaths are avoidable with prompt intervention by a qualified health practitioner working in a supportive atmosphere. Which of the following is indirect cause of maternal death? Whether hemorrhage, unsafe motion, anemia, obstetric labor, heart disease in pregnancy. The indirect cause is heart disease in pregnancy. Last MCQ is, according to WHO, 75% of the nations in the world have high maternal mortality rate. Which of the following has positive effect on maternal health, whether early marriage, female genital tract infection, inadequate nutrition, anemia, or adequate health services coverage?
E.
Yes, it's E. This is the key of the MCQ. This is our YouTube channel by the name of Community Medicine King Edward and Medical University. All the presentation of postgraduate residents are uploaded here. You can go to this channel and can watch all the videos here. And thank you very much for today.